Welcome to Washington Hospital Today, dedicated to informing residents about healthcare topics and issues. Through programs featuring community forums and free health and wellness classes, our goal is to empower community members with the information needed to make informed health decisions. Washington Hospital has been providing health care to the residents of the Washington Township Healthcare District for the past 60 years.
Hello and welcome to today's presentation, Neck and Back Pain Relief, Cervical and Lumbar Disc Replacement, presented by Dr. Eldan Eichbaum, Neurosurgeon with Washington Hospital Healthcare System. Dr. Eichbaum completed his medical degree at the University of California, San Francisco, where he also completed a general surgery internship and 5 years of neurosurgical training. He finished a fellowship in complex and reconstructive spinal neurosurgery at the University of New Mexico in Albuquerque. His affiliations include the American Association of Neurological Surgeons, the California Association of Neurological Surgeons, the Congress of Neurological Surgeons, and the American Medical Association. Please welcome Dr. Eldan Eichbaum.
Good afternoon. I'd like to thank Washington Hospital for allowing me to talk to you today about a pretty common problem, both neck and low back pain. And I've decided to kind of focus on a couple of minimally invasive procedures to discuss treatment for this, and that's artificial lumbar and cervical disc replacement. So why am I talking about it today? Well, first of all, low back pain, as you all know, is a very common problem. It's the most common musculoskeletal problem globally, and it's the second most common problem for people missing work next to the flu. It's a huge medical burden and cost, not only in the treatment, whether it's surgical or non-surgical treatment, but also to people associated with the individual, whether it's at home or at work. Obviously, neck pain is also a very prevalent and disabling problem to take care of as well. So the talk is going to briefly go over the anatomy of the spine, as well as the history of how people come to present to me, what their symptoms are, as well as the signs that I see on the physical examination. And then once I'm able to evaluate them, figure out how to move forward with treatment. And usually we start with imaging studies, and we'll discuss those, and then finally the treatment. And again, I'm going to focus mainly today on disc replacement. So first, let's just talk about the anatomy. The spinal column is there to protect the neural elements and keep us upright and allow us to perform our normal functions. There's three main segments of the spinal column: the cervical, which is the neck or the C-spine, the thoracic, which is the T-spine that's in between the cervical and the lumbar, and the lumbar, which is the lower back or the L-spine. The way that we have our spine arranged is that we want to keep our head over our pelvis. And to do that, there are certain curvatures in the spine that are more normal. And in the cervical spine or the C-spine, there's a slight curvature backwards, or what's called lordosis. In the thoracic spine, it's a kyphosis, or mild curvature forward. In the lumbar spine, again, it's a mild curvature backwards, or lumbar lordosis. And the way that the spine is arranged is that there's an anterior part or a front part, and then a posterior part or a back part. And in between the front and the back part is where the spinal cord and the nerves run from the lower part of your skull down to your tailbone. And so there's bones, which are the vertebra, and the anterior part of the vertebra are called the vertebral bodies. And the vertebral bodies are stacked up like blocks, and then they're separated by discs, which are like shock absorbers. And behind those is where the spinal cord and the nerves run. And then to protect the spinal cord and the nerves on the backside is the posterior aspect, which are called the lamina and the transverse processes. And then there are joints that are connected called the facet joints, which allow for range of motion of our spinal column in a normal way. So all that is stacked up together to protect the spinal cord and the nerves from us injuring ourselves, and the ligaments are there to prevent the spinal column from overextending one way versus the other. So it allows us range of motion, whether it's in the neck or the lower back, and in a normal range of pattern. And if there's an injury, you can have a disc herniation or a ligamentous tear, whatever have you, which then may allow too much range of motion and then cause some pathology and some injury and symptoms. So let's just start with the cervical spine. I have a model here as well. On the screen there, you see on the bottom part here is a sagittal or a side view, which is looking at a cervical spine like this. And you can see, again, the backside is curved a little bit towards a lazy C. And the bones are stacked up like blocks here. And the discs are like shock absorbers in between. The neck has 7 vertebrae. The first one is called C1, or it's like a ring. And that's called the atlas, which kind of holds the head. The next one is called the axis. And that's how we know how to count in the cervical spine from C1 to C7. The axis has a thumb-like projection called the odontoid, or the dens, you can see right here. And that's what the C1 arch rotates around to let for most of our range of motion in lateral rotation and even in flexion and extension. And you can see here on the axial view, or the view which is a cross-sectional view or cut in this plane, is the front is here, the back is here. These are the spinous processes, what you feel in the back when you touch your back side of your neck. The laminar here, here's where the spinal cord runs, and then here's the vertebral body in front where the disc is as well. Okay, so that is what the anatomy is. And if there is any perturbation of that, let's say a disc herniation pushing backwards into the spinal canal or where the nerve exits the foramen, we get symptoms. So in general, when a patient comes to me in the office, there's usually some type of reason they're coming to me. They typically have some type of event that caused them to develop some symptoms, whether it's lifting up somebody, twisting, being in a car accident. Any of those types of issues can cause symptoms in the neck, but they can also just come to me and just say, you know, I just started to have pain and it's not getting better. So once they tell me that, then they also go into their symptoms and then what their signs I can see. So what they typically complain to me about is neck pain. And typically neck pain is worsened when you move your neck with range of motion. Frequently, and what we like to see also, is that they have some type of radicular component, meaning radiculopathy. What does that mean? Well, radiculopathy just means some type of abnormality in a nerve root distribution. That can be pain, it can be weakness, it can be numbness or tingling. Any of those combination of those things can be what we call radiculopathy, and that helps us hone in and localize where the actual problem is coming from. So let's say in the cervical spine, we do know that the nerves from the neck, they travel out the foramen, which is the exit site of the spinal canal, from the spinal cord down into the arm. And we know at certain levels in the neck, let's say C5, 6, the C5 nerve is exiting at that level. And that nerve typically innervates the bicep or flexion of the arm. So if someone comes to me and tells me I have weakness in my biceps, then I'm kind of thinking already it's at the C5, 6 level. There's also issues with something called myelopathy. And what does that mean? Well, myelo means spine in Latin. And so myelopathy means abnormality of the spine. And that's typically, you see that either in the cervical spine or the C-spine or the thoracic spine, the T-spine, because the spinal cord is being compressed, and that can cause other symptoms, not radiculopathy, which means in a nerve distribution, but in a distribution that is causing compression of the spinal cord, which happens distal or below where the compression is. So you can develop symptoms such as spasticity in your legs, you can have weakness in your legs, you can feel imbalance with walking and things like that, because all the nerves that travel into our arms and legs pass through the spinal cord and exit at certain levels to innervate different muscles for strength and and skin for sensation, and also even our bowel and bladder function. So when you hear anything that is somewhat abnormal, we have to work that up. So on examination, we can see diminished range of motion frequently, or tenderness with palpation of the neck. If there's something called the Sperling sign, so if you move your neck backwards and I press down, it can radiate pain down the arm in the distribution where the nerve is being compressed, because when you extend backwards, the foramen or the nerve exit sites is narrowed, and that can cause increased symptoms. You can have weakness, and again, it can be in any distribution depending on where the nerve is being compressed. So I'm thinking if someone has weakness in the biceps, I'm thinking that it's probably the C5-6 level, because that's where the C6 nerve root is, and that's what innervates the biceps. Or they have triceps weakness, that's typically the C6-7 level. So that helps me, again, hone in on where I'm going. Now, there's also a certain pattern of innervation to the skin of the nerves. And so if someone says they have pain or numbness down into the thumb, that's consistent with being at C6. If it's in the middle two fingers, C7. The little finger, it's C8. So again, we can kind of decide the best way to how to work somebody up by first examining them and figuring out where I believe their pathology is coming from. You can also notice diminished reflexes, which is on one side versus the other. That's consistent with a nerve being compressed on one side versus the other. And if the spinal cord is actually compressed, below the area of the compression, the reflexes can be hyperreflexic, meaning they're very more reflexive than you'd expect. And the reason why we frequently have more problems in the neck and the lower back, the cervical spine and the lumbar spine, as opposed to the thoracic spine, the middle part of the spine, is because those are the two areas in our spine that have a lot of range of motion. So that causes a lot of stress to the discs and the joints, and over time it wears down, and it is the main reason why we have most of the issues with our lower back and neck as opposed to our mid-back. This is just a schematic or drawing, which kind of is a cheat sheet for us, and we've learned in medical school, is kind of how the skin is innervated from the neck down to the lower back, and what nerves actually innervate certain parts. And again, you can kind of see that this is a whole anatomy showing that this is at the C6 level, this is the C7, the C8. So when someone comes to me with issues, and I've gone over their examination and their history, and I'm trying to think about what to do for them, the next step is to get imaging studies. So the imaging studies, if you think about, if you had to get one imaging study, the best one would be an MRI scan. And why is that? Well, the MRI scan is the best way to look at the soft tissues, which means the discs, the spinal cord, and the nerves. So that is the ideal modality to get. It's obviously also the most expensive one, but it's the best one if you had to choose one study. But the other studies are still very important as well. For instance, just plain x-rays, which we've had for many, many years, is very important to look at someone to see what their alignment is. Is their alignment normal, curved a little backwards in the neck? Is it getting straighter, which happens as we age and the discs degenerate? Or is it even curved forward, which could be another issue and problem, and help us decide, is that causing a problem? Or it helps us on how to know if someone needs to have a procedure, whether it be done one way versus the other. We also want to see on imaging studies, on plain x-rays or radiographs, if someone has any mobility, meaning if there's a looseness in one or two or even three of the disc spaces, especially when they flex forward and backwards, because again, that also helps decide where their pain or abnormality is coming from and how we treat it. A CAT scan is also very important, a CT scan, and I can tell you when MRI scan came out, everyone thought that a CAT scan would be obsolete, but it's extremely important to look at bone anatomy. It shows us very high quality bone anatomy, helps with planning again to see if there's fractures, what the sizes of the bone is in terms of the pedicle and what the joints look like, which you don't see as well on an MRI scan. Also, and finally, we also can use electrodiagnostic studies. And what is that? Well, something called an EMG or a nerve conduction study. And a lot of times we don't need to use that study if we kind of have an idea that it's coming from the neck and down the arm. But frequently people can have other problems such as carpal tunnel syndrome or ulnar nerve entrapment at the elbow, where the nerves are being compressed either in the wrist or the elbow and can give you similar symptoms than from the neck. And many people can have both. So that can be very helpful in again, diagnosing your problem and treating it, because someone may not need a neck operation, they may just need a carpal tunnel release. So going forward, I'm going to start with just plain radiographs. And if you look at this study, I picked this one because it kind of has different stages of degeneration. On the right side is an AP, or an anterior and posterior view. On the left side is a lateral view. And what you can see here is that if we look at the spinal column, I can tell you that this is C1, and I know that because this is C2. Again, this is this big thumb projection, so I know that's C2. And then the disc spaces are named for the bone that's above and below the disc. So this is the C2 bone, and this is C3 bone, therefore this is the C2-3 disc space. This is the C4 bone, C4 bone, C3-4 disc space. But again, you can see there's different stages of degeneration. Down here, this disc looks relatively normal, but these discs in between are pretty degenerated in age. And that's normal with aging. That doesn't mean that someone is going to have any symptoms from that, but that's normal with aging, and over time it can also help us decide which is the pathologic or symptomatic level. I also showed this x-ray as well because I want to show you a CAT scan next, which shows the same person with a CT scan, but it shows better quality of the bone. So when we're looking at someone, I'm looking at the alignment, and in this person, there's been some straightening of the lordosis, meaning the lordosis should be a little more curved backwards. Now it's a little more straight, but it's not kyphotic or pushed forward. Okay, and again, when evaluating for someone to do a total disc replacement, which I'll go over later, you need to have some disc space available. If someone has a collapsed disc like here, you're really not a candidate for a disc replacement. Now, this is a CAT scan or a CT scan, and this basically shows the bone quality much better. And you can kind of see there's two types of views we're looking at here. The view on the right is similar to the last x-ray we've done here, this view, the lateral, the side view. And what we're seeing here is just, it's facing the other way, but this is the odontoid process, and on this view you can actually see there's a fracture through the odontoid right here. So again, just showing you what the bone quality and the specificity you see that's much better on a CAT scan in terms of bone quality. And you can see here's a normal disc space here, but as we go farther down the cervical spine, the discs are pretty degenerated and narrowed. And if there are big pieces of bone or bony spurs that develop, you can see that better on the CAT scan as opposed to an MRI scan. This is now again a front view, which shows again the fracture through the odontoid here. And here are the joints here between C1 and C2, and this is the disc space of C2-3. But again, now we're going to look at really the modality of choice, which is an MRI scan. On the left side, you can see here is a sagittal view, which again is a side view, and if we look at this model here, we're kind of looking at it, the cervical spine from this view, okay? And what we're seeing here is that here is the bottom of the brain. This is the brainstem becoming the spinal cord as it runs down from the bottom of the skull down to the tailbone, and this is just the area of the cervical spine. This is the front part of the spine, this is the back part of the spine, and here's again the odontoid process, which means this is cervical or C2, the C2-3 disc space, C3, the C3-4 disc space, C4, C4-5 disc space, and onwards. So we're looking to see here in this view, it looks like a normal scan basically, because there's no significant disc herniations pushing on the spinal cord. There's spinal fluid in front of and behind the spinal cord, and here are the bones in the backside. The view on the right is called an axial view. So instead of looking at it from the side, this is now a view looking at cross-sectional, or if you were lying, let's say, like this. And I explained to my patients that basically think of this view as you lying through the screen, your body's lying through the screen with your feet behind it, your head through it, and we're making a slice cross-sectionally. So here, And then also left is right and right is left on the scan. So this is the left side of the neck muscles and the back part of the neck. This is the right side. This is the front part. This is where your throat is. And then here's the spinal column, and here's the spinal cord itself in cross section. The spinal cord is in the spinal sac. The white is fluid. This is where the disc or bones are in front, and here's the bone in the back. And this looks pretty normal, okay? So in general, most patients that I see are non-surgical. And even though I'm a surgeon, most people that come see me, the vast majority do not require surgery. Only about 80% don't need surgery, about 20% need surgery. And the mainstay of treatment is physical therapy. And why does that work? Well, I can't tell you exactly why it works, but it does. And I think the combination of doing exercising and strengthening your muscles that support the spinal column, bringing blood flow there, and letting the body heal itself is the best thing. And that's what physical therapy works. You can also try other things such as chiropractic care, medical management such as taking anti-inflammation medications and multiple other medications you can try, even that are non-narcotic, that can help you with your pain syndrome, as well as acupuncture. Now, if these treatments fail, the next step is typically a trial of injections. And what is that? Well, injections are steroid injections, which means they're very potent anti-inflammation medications, which are placed right in the area where the nerve is being compressed and causing inflammation and pain, and it stays there for quite some time and gives you relief for quite some time. In fact, most of the time people get better because eventually the body heals itself. Now, if someone doesn't get better with that treatment, or if they have a neurologic problem such as significant weakness or disabling pain, then surgery is recommended. Now, there are basically two approaches to perform surgery on the cervical spine or the neck. One is an anterior approach from the front. One is a posterior approach from the back. We're going to focus on the anterior approach today, and basically it's the most common procedure done in the cervical spine, and the most common procedure is called an anterior cervical discectomy and fusion. And what does that mean? It's a lot of words. Anterior means from the front, cervical means the neck, discectomy means removal of the disc because that's pushing back on the spinal cord and or nerves. And then once you remove the disc, something has to replace the disc so the disc space and the bone above and below doesn't collapse down and the exit sites for the nerves narrows. So that's what we do. And then a disc replacement is basically the same procedure, except instead of placing a piece of bone or a cage with bone and a plate to hold it in place, we put in a prosthetic disc. So the indication for this surgery is neck pain, radiculopathy, like we talked about, pain or numbness or tingling or weakness in a nerve distribution, myelopathy, spinal cord compression, and generally if the patient has some type of disc herniation that's not way lateral, that's just pushing on the nerve, which we can get maybe from the backside of the approach. If it's central, in the middle, or over to the side, those are the best reasons to perform this operation. So this is just an example of someone that had an anterior discectomy and fusion at 2 levels. And you can see here on the x-ray, this is a side view or a lateral view. Here's the mouth and here's the throat. You can see the trachea here. There's air in the trachea. Here's the esophagus. That's the swallowing tube. And you can see the bone. This is cervical 2. Here's a C2-3 disc space, C3-4, C4-5. So this person had a C5-6 and C6-7 anterior discectomy and fusion. So I removed the disc from the front, replaced it with a piece of bone at both levels, and then a plate to hold it in place. And in general, the reason we do that is because, as I said previously, once the disc is removed, something has to replace to keep that disc space height normal, or even better than it was before, to promote that the exit site for the nerves are open. And also, you have to fixate that area so that the pain that develops from any micro movement there is eliminated, okay? So this is a great procedure. It's been done since the 1950s, and there's excellent results with this procedure. The main issue with this procedure is that over time, when you fixate the spine, it does add stress to the disc levels above and below. And what does that mean? Well, in general, it's not that big of a deal, but as that stress level occurs over time, it can cause acceleration of the degeneration of those discs that are either higher or lower than the fusion site. And if that happens, that can cause symptoms that eventually require surgery. So if you have a procedure that allows you to retain range of motion and still get the same result as a fusion, that's preferred. And that's what we're going to talk about disc replacement. This is just to show you, I hope no one's that skittish, but this is just to show you how we make the procedure here. It's a very small incision, maybe about an inch, inch and a half in the neck on the side. And we retract, or you can see I'm having two retractors here, handheld, that are retracting the trachea, which is the breathing tube, and the esophagus, the swallowing tube, over to one side. I'm retracting the carotid artery to the other side. That's what feeds the brain. And then performing the procedure. And again, you can kind of see on this model here that that plate, you see there, it looks like this. And that's how it looks. Okay? So we used to do all these procedures without putting any internal fixation or plate with screws and things inside. And people had to wear braces to keep the neck immobilized to promote the fusion. Now that we have this internal fixation, we don't really need them in general. And also, this is just to tell me that I want to talk about disc replacement now, because when you have a disc replacement, you don't need a collar. So the indications for disc replacement is basically the same as a discectomy and fusion. There are some things that you have to have, though, to be a candidate. And in general, it's just approved now for people anywhere ranging from the age of 18 to 62, but I'm pretty sure that that can be extended. The main issue is you have to make sure that the disc height is relatively well preserved, meaning that there is still about at least 3 to 4 millimeters of disc height to allow you to place this prosthetic disc in the same place. You also can't have any significant kyphosis or curvature forward, or any instability where one bone is moving on the other over the disc space. That also puts too much stress on the joints in the back, which are the facets, and therefore you won't be a candidate. And this is just, again, to show you the procedure that's done. It's done exactly the same way as performing a discectomy and fusion. You can see that we use some instruments in the surgery where we're basically removing the disc, and then we are able to place this prosthetic disc instead of the disc instead of the disc and the fusion. And what that does, the disc replacements are generally made of usually two types of, usually a metal above and below, and in the middle is a polyethylene core, which allows, again, range of motion to remain at that disc level, and therefore also not put too much stress on the disc levels above and below like a fusion would. So this is just an example of a patient that I had about 4 months ago, who had years of neck pain and arm pain. It was tolerable, but then became rather severe about 5-6 months ago. And you can see this is his MRI scan. And again, this is a sagittal or side view, which shows C2 and C3, C4, C5, C6, and C7. What you see here is that as the spinal cord is coming down, at this level of C6, 7, there's a pretty large disc herniation. You see that? And it's coming and just about touching the spinal cord. The view on the left is called an axial view, and again, I just took one picture of it to show you that on the axial view, these are the muscles on the back again. So this is the left side, this is the right side, and he had left-sided symptoms. And you look here, here's where the spinal cord is. The white behind it is the spinal fluid, but you don't see it in front anymore because this disc herniation is present. And it's kind of from the right to the left, but much more severe on the left. This is where the nerve is exiting on the left, and that's what's causing his problem. So because he had well-preserved disc height, he was a young man in his 40s, he was a great candidate for this procedure. And this is what happened. So this is the procedure that was done. You can see on the side view that here's the disc prosthetic, the prosthetic disc here. On the side view and on the front view, it looks great. And he's done very well. He's back to surfing, skiing, and other activities. And this is just another type of disc replacement from a different company. Again, on the side view here and a front view here showing the same kind of result. So just to quickly just go over the lower back, it's basically the same thing, okay? So again, neck or cervical spine, low back, lumbar spine are mobile segments of our spinal column, and they get a lot of stress and cause a lot of issues. You can get, just like in the neck, low back pain, as well as in the lower back. The symptoms generally are in the legs, not in the arms, because in the neck, the spinal cord gives off nerves that go into the arm for innervation. In the lower back, the nerves go into the legs. So you typically have the same symptoms of leg pain, numbness, weakness, things like that. On examination, again, it's basically decreased range of motion of the lower back. You can be tender there. You can have leg weakness. You can have decreased sensation and diminished reflexes. All of these things are a possibility, just like as we talked about in the cervical spine. In the lower back, it's similar as to the neck, except the vertebral bodies and the spinal column is bigger because you have more weight on that area. So again, on the side view of the lower back, you can see here on this schematic here, the vertebral bodies are here, stacked up like blocks. The discs are like shock absorbers in between, vertebral body, disc, and at every level, a nerve comes out in the foramen, which is the opening right here, to innervate the muscles in a certain part of the leg for strength and the sensation on the skin. Again, we do the same workup after someone comes in with the complaints of back or leg pain, whatever have you. We are then able to further our workup with imaging studies, and the same goes for the cervical spine as the lumbar spine in terms of imaging studies. And here's just an example of the lower back. On the left side is a side view. On the right side is a side view, and the left side is a front view or an anterior view. And you can see the bones are stacked up like blocks, and the discs are like shock absorbers. And the question is, how do we count the lumbar spine? How do I know where L1 is or L3 is? Well, the sacrum is what we count from the bottom. So this is S1, so we know this is the sacrum. And then this is L5, L4, L3, L2, and L1, okay? MRI scan here is a relatively normal looking MRI scan. On the left is a side view, on the right is a top view. Again, the bones are stacked up like blocks. Here are the discs. And again, here's the sacrum. So this is S1, this is L5, this is the L5 S1 disc, L4 5 disc, L3 4, etc. The one difference in the lumbar spine and the cervical spine is that the spinal cord, which is a very sensitive tissue, comes all the way down and ends in something called the conus, which we see right here, right around the end of the thoracic spine or the upper part of the lumbar spine. And it gives off all these nerves that look like a horse's tail, and therefore that's called the cauda equina. And you can see that the nerves are kind of floating in the spinal sac here, which is the fluid, the spinal fluid here. So on the cross-sectional view, you see the disc in front, the facet joints in the back, and the lamina in back. But here's the spinal sac in cross-section, and instead of seeing one thick spinal cord, you're seeing the dots, which are the nerves. And in general, the lower back is much more malleable in terms of, like, the nerves can be relatively severely compressed, and it's not that concerning. But in the cervical spine, if the spinal cord is compressed, it's much more concerning. This is just to show some pathology, some abnormality. You could see here there's a lot of degeneration of the discs here. The nerves are coming down the spinal canal, and there's pretty significant narrowing, or again, the term for narrowing we use is called stenosis, at the level of L4-5 here, and there's even a slip of the bone at that level. And on the axial view, or the cross-sectional view at that same level, you see the joints here are arthritic and overgrown, the disc is bulging back, and the spinal canal is narrowed because of all of that. And this is just the CAT scan of that same individual, just showing how you have arthritic changes in the joints, and again, you see that much better on the CAT scan. The treatment is basically the same as for the cervical spine. Most people get better with physical therapy and medical management. You could try any of those options: physical therapy, chiropractic care, acupuncture, and injections. And again, if they fail that those treatments, then the next option is surgery. And again, there are several ways of addressing the lower back issue with surgery. As opposed to the neck, where we typically go from the front or the anterior part, in the lumbar spine, we typically go from the back. People have what we call laminectomies or laminotomies or discectomies. That's typically from the back because we can manipulate the nerve roots in the lower back, which we can't do in the neck in general. But again, I'm going to focus on the anterior approach because, number one, it's minimally invasive, and number two, the only way that we can do a disc replacement at this point is from the front or an anterior approach. And again, there are advantages and disadvantages of a posterior approach, which we're not going to go into. But we like to do things minimally invasively, and whenever we can. There's less muscle retraction and trauma, and there's smaller incisions. So in order to do a disc replacement in the lumbar spine, we have to go through an anterior approach. But as opposed to the neck, where there's not much in the way, in the lumbar spine, there's a lot of things in the way. There's the kidney, there's the bladder, there's the bowels, there are blood vessels there. And so to get there, it seems like it could be a big problem. But in general, we can make a small incision and kind of just move things over to get to the spinal column in a relatively easy way. Let me just show you. So in any event, that's how it's done. So this is just an example of someone who I've done a fusion on, and again, very similar to in the cervical spine, where the disc is removed and replaced with a cage filled with bone. You can see here on the side view, this person had a discectomy and fusion from the front at L4-5 and L5-S1, and a cage was placed, and then through the muscle on the back, I placed screws and rods to hold everything in place, and he's done very well. Now again, because of this level here, L3-4, is going to be more risk in the future developing issues with degeneration and problems as opposed to doing a disc replacement. Now, a disc replacement, again, allows range of motion to be retained, and it also decreases the risk of putting too much stress on the disc levels above and below. And so again, if you're a candidate, typically between the same age we talked about, between 18 and 62, your disc height is relatively well preserved, you mainly have back pain with maybe some leg pain, but not much what we call stenosis, and your joints are relatively intact, you can have a disc replacement. And this is kind of how it's done. Again, you can see here on the left, we make a small incision and we kind of retract all those structures we talked about out of the way, get down to the spinal column, and then perform the discectomy, and then get sized up to the correct size of the implant, and then place it in there. And this is kind of what it looks like. We use X-ray in the surgery to help guide us, placing it in the correct position, and then we place the prosthetic disc in here. And this is just an example of one of my patients here that I had done about 3 months ago. He's a young man, which again, in general, young people, we try to avoid surgery as best as possible, but he had 4 years of pain. He underwent all treatment modalities. He was disabled by his pain. And the scan shows on the left side of the MRI scan, you see the lower two disc levels, L4-5 and L5-S1, have degeneration and some disc herniation, but it's not that stenotic, or there's not much narrowing there. And this main symptom was back pain. So he decided he wanted to have surgery, and I looked at his studies, and I can just tell you at the lowest level, the L5-S1 level, his joints are somewhat abnormal and arthritic, and therefore I didn't think that level would be adequate for a disc replacement. But the level above, L4-5, had normal joints and was relatively normal, and therefore I felt that we could do what we call a hybrid procedure, where the first level, the L5-S1 level, has a discectomy and a fusion, and the level above, L4-5, has a disc replacement. And this is kind of what it looks like after surgery. Here's a view from the side on an X-ray. Here's the fusion cage with screws holding it in place, and here's the disc replacement prosthesis right here. And this is a front view. And then this is just a CT scan that shows everything a little more clear. Again, the disc replacement at the L4-5 level on the side view, and here's the fusion cage on the next level down. And this is just showing another patient I did years ago. Just had a single level disc replacement at L4-5 and did very well. So in conclusion, low back and neck pain are very common. The majority of people improve with non-operative modalities. And surgery is an option for people who fail non-operative management, or they have signs and symptoms that correlate with their imaging studies, they failed non-operative modalities, or they have any type of neurologic abnormality. We obviously prefer minimally invasive techniques, and a total disc replacement is an excellent option for the reasons we discussed earlier. Thank you. Any questions?
Thank you, Dr. Eichbaum. We do have a couple of questions coming in through Facebook. One person asks, what's the recovery time for minimally invasive disc replacement?
In general, people do very well. Usually they're home, at least in the cervical spine, can go home the same day or the next day. In the lumbar spine, again, usually the next day or the day after. In terms of the lower back, sometimes people can get some constipation because we kind of move the bowels out of the way. But in general, people are up the same day of the surgery and can be home within 24 hours.
Great, thank you. if somebody's having back pain, when's the right time to go and see a neurosurgeon?
That's a great question. It all depends really on their symptoms. If it's just new onset of back pain and it's not that significant and it gets better with anti-inflammation medications, there's no rush. But if it persists and someone is having significant severe pain that really can't be explained, then it's probably better to be seen by their primary care doctor and then undergo imaging studies as soon as they can, especially if there's associated extremity issues, whether it's in the neck or the lower back, so into the arms or the legs.
Great. Which has faster recovery time, a disc fusion or a disc replacement?
In general, we feel that the disc replacement has a faster recovery time because in general, when you have a fusion, we want to immobilize your spinal column that was operated on. When you have a disc replacement, typically we let you move your neck or your lower back sooner than you had a fusion.
And the final question is, somebody's been referred to a physiatrist. Can you talk about the role of the physiatrist with back pain?
Yes, they're an excellent type of physician. They are rehab physicians that can help with all the non-operative modalities in terms of like exercising and physical therapy, and even some of them do injections as needed. So they're probably the first, after your primary care physician, they're the next approach to deal with this problem, especially if you're non-surgical.
Well, thank you, Dr. Eichbaum, for this great presentation. This concludes our program today. Thank you, viewers, for tuning in for the entire broadcast today. The broadcast will be available on our Facebook page and also on our InHealth YouTube channel.